to this HIPEC Facebook Live event entitled Treating Peritoneal Disease with Cytoreductive Surgery and HIPEC, hosted by HIPECtreatment.com. Our presenter this evening is Dr. Benjamin Powers, an assistant professor at the University of Maryland, Department of Surgery, an associate member of the University of Maryland Greenebaum Comprehensive Cancer Center. Dr. Powers completed his surgical oncology fellowship at Moffitt Cancer Center in Tampa, Florida, and is an expert in treating peritoneal cancers with cytoreductive surgery and HIPEC. My name is Glenn Keeling, and I will be your event moderator for the Q&A session following Dr. Powers' presentation. You will be able to message your questions using the Zoom Q&A option during the presentation. I will present the questions at the end of Dr. Powers' presentation, and he will answer your questions. The HIPEC Facebook Live event will be recorded and posted to HIPECtreatment.com for future viewing. At this time, it is my great pleasure to introduce the HIPEC Facebook Live presenter, Dr. Benjamin Powers, University of Maryland, Department of Surgery.
Thank you very much, Glenn, and thank you to HIPECtreatment.com for having me and the ability to share my presentation today, Treating Peritoneal Disease with Cytoreductive Surgery and HIPEC. I don't have any disclosures. However, HIPEC is an off-label use, and there will be some operative pictures that I've included. The goal for today is to describe the peritoneum and peritoneal disease, and also discuss cytoreductive surgery, HIPEC treatment, and some outcomes. So first, wanted to discuss the peritoneum. I think that for a lot of patients, when they are initially diagnosed with peritoneal disease, it may be the first time that they have ever heard this word. It's often an overlooked site of disease, and I think it's important to sort of discuss this so that patients have a little bit of an introduction to what we're talking about and what we're thinking about when we think about peritoneal disease. But it is a place, as the next few slides will show. The peritoneum is a membrane, and it lines the abdominal cavity in addition to several organs within the abdominal cavity. This includes the diaphragm, liver, pancreas, spleen, as well as the gastrointestinal tract from the stomach to the small bowel, the colon, and the rectum. It also includes the omentum, the uterus and ovaries, and the bladder. As you can see here in this cartoon, this highlights the gastrointestinal tract that extends from the esophagus to the stomach, the small intestine, the colon, and down to the rectum and out the bottom. I've included this little drawing here of the peritoneum, which, as you can see, this membrane lines the entirety of this abdominal cavity. And from another angle, you can see the potential space here in light blue that could have fluid or disease in patients that do have peritoneal disease. And the peritoneum here is now outlined in the darker blue section. So where does peritoneal disease come from? It can come from the peritoneum itself, and that is most commonly called mesothelioma. However, the gastrointestinal tract and ovaries are more common sites of origin of peritoneal disease. And this again can include most of the organs from the stomach down to the rectum, as well as the pancreas and bile ducts. Here you can see in this cartoon, when disease gets outside of an organ, be it the ovaries or a part of the gastrointestinal tract, typically we see the spread of peritoneal disease from the site where it originated in a traditional pattern, and this can extend throughout all of these potential spaces within the abdominal cavity. And here you can see in this cartoon, disease can then attach at different portions of the peritoneal membrane in this process called reseeding. And as this disease bounces around, ultimately it will attach and adhere to portions of the peritoneum. However, there are treatments for peritoneal disease, and peritoneal metastases, when optimally treated, can be cured. The goal is to eliminate local regional recurrence and peritoneal metastases from the natural history of gastrointestinal and gynecologic malignancy. This quote was taken directly from the Peritoneal Surface Oncology Group International, or SOGI. So what is cytoreductive surgery and heated intraperitoneal chemotherapy? Well, this is a surgical treatment that's applied to select instances of peritoneal disease spread. The goals of CRS HIPEC are to offer a chance for cure, to improve survival, and relieve symptoms of disease. Additionally, it can prevent future symptoms and improve quality of life. And a huge benefit of cytoreductive surgery in HIPEC is that for certain patients who may be on systemic treatment, including chemotherapy, it can offer time away from this. However, not all patients may benefit from chemotherapy or systemic treatment. In terms of determining who is a candidate for cytoreductive surgery in HIPEC, there are really three main factors, but also some other considerations. First is underlying tumor biology. That is, where has the disease started and come from? The stomach, appendix, colon, for example. What is the extent of disease? How much of it is in the abdominal cavity? And three, can we achieve what we describe as a complete cytoreduction? That is, remove all of the tumor. Some other considerations are patients having symptoms? What is their performance status? That is, the overall health of the patient. In addition, response to other therapies. Have patients responded to chemotherapy or other treatment that they may be receiving? Here you can see the peritoneal cancer or carcinomatosis index. This is a commonly used scoring system that helps us delineate the extent of disease. Each lesion gets a score in terms of its size, and this is calculated as we move through the different regions, as you can see on the diagram here, as well as the 4 sections of the small bowel. And here you can see the complete cytoreduction categorization system is what we use to determine how much disease has been removed. Optimally, we will get a complete cytoreduction where no disease remains. However, in certain circumstances, and when disease is attached to certain organs, such as the liver, which can't be removed, then patients may get a higher cytoreduction score. In general, the operation can be broken down into 3 phases. And it's important to note that this all occurs at the same time under one surgery, but that there are 3 parts or phases to it. The first is cytoreduction. That involves taking out all of the disease. Are we able to remove all visible disease in affected organs? And as you can see here in these 2 photos, there are some areas of peritoneal disease here on the omentum that's attached to the colon here, as well as a section here of peritoneum, including a portion of the rectum that needed to be removed to get all disease out of a patient's pelvis. This diagram shows how we can really think about cytoreductive surgery and HIPEC systematically. Here in this cytoreductive phase, you can sort of see that things are broken down into peritonectomies, where portions of the peritoneum that have visible disease on them may need to be resected to get it out. And that can be disease that's on the diaphragm or the liver capsule or even in the pelvis. And then visceral resections, that is, organs within the abdominal cavity. So this can include things like the omentum, the uterus, the ovaries, the colon, appendix, small bowel, spleen, pancreas, as well as the stomach, or any urologic procedures such as resection of the bladder. In addition, if there's disease that is stuck to portions of the peritoneum at the abdominal wall, that may need to be resected as well. So given the potential extent of disease, it's very important to always be prepared to sort of go anywhere within the abdominal cavity, and why cytoreductive surgeons are really so meticulous at making sure that we look absolutely everywhere to identify and remove disease so that none is left behind. The second phase of the surgery is HIPEC, the heated intraperitoneal chemotherapy. This is essentially a hot chemotherapy bath that can be given for anywhere from 30 minutes up to 2 hours. Most commonly, it's given for 60 to 90 minutes. And the whole goal of HIPEC is to treat any remaining microscopic disease. Here in this cartoon, after a patient has undergone cytoreduction, how we proceed with HIPEC is to first insert an inflow and outflow cannula that is connected to a perfusion machine. The machine then heats fluid that then circulates within the abdominal cavity, and the chemotherapy is then added to that perfusion to slowly go through the process of being heated and then entering the abdominal cavity to treat any of that microscopic disease. And here's an example of a perfusion machine that would be used to perform HIPEC. Finally, once all disease has been removed and any remaining microscopic disease has been treated with HIPEC, the final phase is reconstruction. And this is where any bowel that's needed to be removed is reconnected or anastomosed and put back together, and if necessary, an ostomy is created. So while this was a brief and short overview, I hope that it gives you some idea of sort of what is entailed within cytoreductive surgery and HIPEC, and that it can be a rather complex operation that involves resection of quite a bit of disease. However, survival outcomes are good in select cohorts, and this has been shown in both some randomized clinical trials as well as in retrospective cohort studies. However, we do need data-driven tumor biology approaches to optimize our treatment. In addition, I think further research could be very beneficial to helping identify the exact role of HIPEC and also create new tools to help treat peritoneal metastasis. And just to briefly highlight, this is one opportunity that we have that we are looking into here at the University of Maryland, looking at cancer cell targeted photoimmunotherapy, and this is being done with my lab in collaboration with my partner Dr. Huang, who's in the Fischel Department of Bioengineering at the University of Maryland. So this will conclude my talk. If you have any questions, feel free to ask them in the chat, and to contact me and schedule a consultation, you can give us a call at 410-328-7320. Thank you again.
Dr. Powers, we do have some questions coming in. Question number one, how much do untreated peritoneal metastases contribute to cancer recurrence?
So we know that for patients who undergo cytoreductive surgery and HIPEC, that despite all efforts to remove disease and even remove all visible disease and then use HIPEC, there can still be a relatively high recurrence rate. For example, for colorectal peritoneal disease, the recurrence rate can be anywhere in studies, it's been shown to be 60 up to 73% in some studies. So I think that's why in a lot of cancers, depending on, again, the origin and where it comes from, what we really like to do is optimize all tools in our toolkit. And this means combining cytoreductive surgery and HIPEC with things like systemic treatments, immunotherapy, chemotherapy, and other targeted therapies.
Okay, another question coming in. How do you determine if someone will or will not benefit from traditional chemo versus HIPEC?
So a lot of it is based on data that we have that is sort of organ site specific. The standard treatment for most patients, for example, with stomach cancer that is spread to the peritoneum, colon cancer, rectal cancer, small bowel cancer that's spread to the peritoneum, is what we call systemic therapy, and that is chemotherapy. So commonly we will give patients several cycles of this treatment, usually anywhere from 3 to 6 months, and then reassess how their progression has been under chemotherapy. That often involves restaging imaging with CT scans to assess the extent of disease and if there's been a good response. And it may even involve diagnostic laparoscopy. That is an outpatient procedure where we will go in with a camera and assess the peritoneum directly so that we can have an idea and get a reasonable estimate of what sort of the peritoneal cancer index score may be in those patients to then determine if cytoreductive surgery and HIPEC would be beneficial. And so our first goal in surgery and in all of medicine is to do no harm. So we want to make sure that we select the right patients who are good candidates for this procedure. And so again, oftentimes we are using chemotherapy in concert with cytoreductive surgery and HIPEC.
Now the question, Dr. Powers, how often is total cytoreduction limited to a single surgery?
So I think for most patients who undergo cytoreductive surgery and HIPEC, this tends to be a single surgery that we use to be able to take out all disease at that time. Again, the overriding principle of cytoreduction is that all visible disease is removed. However, there may be select circumstances in which doing cytoreduction over 2 separate surgeries may be beneficial. This most commonly is used in patients who have what is called appendiceal mucinous disease or low-grade appendiceal mucinous neoplasm, where it may be beneficial to split the surgery into 2 different procedures. However, overall, that is incredibly rare that we can't go in and get all disease out in one surgery. And that tends to be the goal of what we're trying to accomplish here and sticking to the principle of getting a complete cytoreduction.
Another question, how common is it for cancers to spread from the organs to the peritoneum?
Well, overall, it's quite rare. That being said, there are certain diseases within the abdominal cavity where it can be a little bit more common. I think when we think about appendiceal tumors, for example, which can be a very common reason to perform cytoreductive surgery and HIPEC, these are described as rare diseases, and for that, it overall is a relatively uncommon procedure. However, some patients with colon peritoneal metastasis with colon cancer, the rate of patients who may have peritoneal disease can range anywhere in certain cohorts from 10% up to 30 and even 40%, depending on the studies. What we commonly see is that there can be patients who have peritoneal disease from colon cancer, for example, where it's also gone to other organs as well. So again, this is why typically this type of disease is treated at higher volume select comprehensive cancer centers that are well equipped to be able to treat this.
Next question. Why does HIPEC have to be hot? Why does the chemo have to be hot?
I think that in general, one of the reasons that we use the hyperthermia is that that's been shown to help facilitate uptake of chemotherapy within cancer cells. There's a lot of good basic science data that's shown that it really can be beneficial when we get the abdominal cavity hot to facilitate that uptake. And so that's the real benefit. Oftentimes you'll see it described as a synergy working with the hyperthermia, which in and of itself has been shown to be cytotoxic to cancer cells, and helping with the uptake of chemotherapy into cancer cells to treat them directly and be lethal to those cancer cells.
Okay. How long has HIPEC been performed in the United States?
That I don't know. I think that the first surgeries were performed, I believe, in the late 90s. That being said, I know that there were studies and it wasn't really routinely performed until the late 90s, early 2000s. When we go back and look historically, I believe that I'd be at pains to say the exact date, but I think some of the first trials were even in 1976, but heated intraperitoneal chemotherapy has been around for quite some time, and it's been sort of routinely used for well over 30 years, I believe, in the United States.
Okay. After a patient has HIPEC, would they need to go on chemo afterwards?
Again, I think that would sort of depend on the disease site that's being treated. For a lot of patients, if they are using some having some type of recurrence or something like that, it may be beneficial, or if we can't obtain a complete cytoreduction, they may need to go on systemic treatment afterwards. But for the vast majority of patients in whom we're able to get a complete cytoreduction, I think in general, most physicians and most treatment centers will actually avoid putting patients back on systemic treatment. And as listed in the slides, that's one of the benefits, is that patients are able to avoid going back on chemotherapy and go on to surveillance after cytoreductive surgery and HIPEC, until there may be a recurrence down the road. Ideally, that doesn't happen, but in general, that can be a benefit, as that cytoreductive surgery and HIPEC offers that opportunity to have time away from chemotherapy.
Okay, last question. What sets the cancer program at the University of Maryland Greenebaum apart from others?
So I think what's really unique about the University of Maryland is that we have a very strong tradition in cytoreductive surgery and HIPEC. This has been something that I, coming to the University of Maryland relatively recently, and prior to that, being at another facility where I spent a lot of time doing cytoreductive surgery and HIPEC, I'm really standing on the shoulders of giants in the work that's been done here previously. The University of Maryland has performed over 600 cytoreductive surgery and HIPECs since the procedure was started to be done, I believe, roughly in the late 2000s, around 2006, 2007 was when it was first performed here. And so there's been a very established pathway for patients to be treated with peritoneal disease at the University of Maryland. And so now, being a new faculty member, I'm helping to really take that to another level and combine that with basic science and translational research to open up new clinical trials and opportunities for patients to obtain novel treatments. So I think that sets the University of Maryland a little bit apart from other centers that may not have quite the extended history of cytoreductive surgery and HIPEC.
Dr. Powers, that seems to be the last question. I want to thank you very much for the great presentation and your time this evening. And thank you, everybody, for attending our HIPEC Facebook Live event. Good evening, everyone. Thank you.
Thank you very much, Glenn.